So first of all, can you tell me a bit about yourself?
Sure. So, I've been working as a medical journalist, writing about medicine and science for about 30 years. I worked as a newspaper reporter for a long time. Then I wrote a lot for magazines. For a while, I was director of publications at Harvard Medical School. So that's my background. Basically just a journalist writing about medicine and science. And then in 1998, I did a series for the Boston Globe related to abuses of patients in psychiatric research settings. And that's what got me writing about psychiatry. And for the past 10 years, I've basically just been writing books.
Great. And you recently wrote a book called Anatomy of an Epidemic,
right?
Which has become very popular. Can you summarize this book for our listeners?
Sure. So, Anatomy of an Epidemic was meant to take a big picture look at whether this paradigm of care that we have, which is so drug-centered, so drug-focused, first of all, is it working for us as a society, right? Is it reducing the burden of psychiatric distress in our society, in Canada, in Ireland, etc.? And what you find very quickly is the answer is no. In other words, the burden that depression is taking, the burden that bipolar is taking, the burden that other psychiatric disorders are taking has skyrocketed in the last 20 years. And one way to measure that is to measure by the number of people on disability. In other words, they can't work, so they have to be supported by the government. So all those markers are telling us that this paradigm of care that we've embraced, where we spend more and more money on medications, it's just not working from a societal point of view to lessen psychiatric distress in our society and help people go back to work. So that's the first part of it. Then the second part of it is, and this I think is why the book's getting some attention, is to look at this question: how do medications shape long-term outcomes? In other words, how do they shape the long-term course of schizophrenia, or the long-term course of bipolar, or the long-term course of anxiety or depression? And I honestly believe it's the first book to really try to see what 50 years of science tells us an answer to that question, okay? Because the evidence base for psychiatric medications is so limited. It's really, okay, do they knock down a symptom over the short term? That's one. And the second part is, once you're on, when you come off, are you at high risk of relapse? And the answer is, once you're on and do go off, there is a high risk of relapse. But that's not telling you how you're shaping long-term outcomes. And what I did in this book, really tried to trace that over 50 years, and what you find, I know this seems odd, is that outcomes have deteriorated in the medicated area. They really have, notably. And with the affective disorders, depression and bipolar, you see that they've been transformed from episodic problems into much more chronic problems.
And what you're saying is really contrary to the received wisdom of psychiatry as a profession or an institution. How has your book and your findings been received by people in psychiatry, people with mental illness, family members?
Right. Well, it's indeed it's like being a heretic, right? It's like committing heresy, because there's a societal belief, there's a professional belief, and that belief is that the medications are essential and have improved outcomes, that they are part of a, quote, psychopharmacological revolution. So whenever you commit an act of heresy, you upset people and you get attacked and that sort of thing. And often they'll attack the messenger. But what seems to have happened, now the book came out 18 months ago, is that more and more professionals, family members, people who use the medications are really trying to grapple with the information in the book, the research in the book, and they're finding that, it has scientific merit, is the only way to put it, that it's based on reason, it's based on mainstream science, and I think they're finding that there's sort of almost a moral obligation to grapple with it, if we care about the system of care. And I want to say that's within pockets of psychiatry, within pockets of, quote, consumer groups, within pockets of providers. And I think the number of people doing so are expanding groups, but there's plenty of people still wanting to burn the heretic. Okay?
Okay. If, in light of your findings, if a health policy expert or a government member came to you and said, what should we be doing to change the psychiatric system to make it more recovery-oriented or to help people, what would you say?
Well, I would actually say the first step would be to look at this long-term outcomes data and see that we need to have change, because clearly we have early death problems, we have deteriorating outcomes, cognitive decline, physical problems, etc. So first thing is just to incorporate this long-term outcomes and say, wow, we need to make a change. But I think at the same time, science is telling us with actually great clarity that we humans are social beings, and that mental health and the capacity to thrive happens within a social context, which is involving friends, finding meaning in life, having relationships. And so I think what science is telling us is that what we need to do is provide this sort of intensive psychosocial care that help people maintain friendships, find meaning, find physical wellness, good nutrition, that sort of thing, and then would completely rethink the use of meds, and rather than being the centerpiece of care, they would become like adjuncts, and you would figure out when to use them, for how long, and they would be used in a much more selective, cautious fashion.
Okay. Well, Robert Whitaker, I would like to thank you so much for spending your time talking to us today, and thank you for coming to Montreal and talking, and I wish you well in the future.
It's been a real pleasure being here. Thanks so much.
Thanks.